My name is Erica Pennick, and I am the Executive Director of the President's Council. While we have gathered this evening for our Ask the Experts webinar, events of today at our nation's capital have certainly refocused our attention not only to the health crisis of this nation, but our safety and democracy. We appreciate you joining us in this vitally important conversation for our community, designed to bring transparency as well as provide direct question and answer. Today's webinar, Ask the Experts COVID Vaccination, is brought to you by the President's Council and in partnership with Cleveland Clinic. This webinar is being recorded and will be available on the President's Council's website. We also encourage and welcome the opportunity to connect via phone, email, and web chat. Before we get started, please note your video should be automatically turned off and devices muted. If not, do so at this time. As you have questions or comments, please insert it in the Q&A thread, which will be used to ask our presenters at the end of the presentation, along with questions submitted by participants during registration. We will also allow for open Q&A before the end of the session. During this time, if you have questions or comments for a presenter, please click the raise your hand button and we will pause to recognize you, at which time your device will be unmuted and your video turned on. Today's presenters are medical doctors Lee Kirksey, Dr. Melissa, and Dr. Stephen M. Gordon. Dr. Kirksey is Vice Chairman of the Department of Vascular Surgery at the Cleveland Clinic Sedale and Arnold Miller Family Health and Vascular Institute. As an Ohio native, Dr. Kirksey received his undergraduate and medical degrees from The Ohio State University and is board certified in surgery with special qualifications in vascular surgery. Dr. Kirksey holds a master's in business administration from New York University Stern School of Business and holds the Walter W. Buckley Endowed Chair. Dr. Melissa is one of the medical directors in Cleveland Clinic's medical operations, leading the clinic's efforts in community COVID-19 testing and vaccine deployment. She is also the medical director of the clinic's Asia Pacific Strategic Operations, guiding the clinic's growth in the Asia Pacific region. She is an endocrinologist by training, and her clinical interests are diabetes and diabetes technology. She is a graduate of Columbia University and Stony Brook School of Medicine. Dr. Melissa completed her residency training at New York University and her endocrinology fellowship at Georgetown University Hospital and Washington Hospital Center. Dr. Melissa joined Cleveland Clinic in 2009. Dr. Gordon is chairman of the Department of Infectious Diseases at the Cleveland Clinic Foundation and professor of medicine at the Lerner College of Medicine at Case Western University. Dr. Gordon served on the Health Infection Control Practices Advisory Committee 2003 to 2007, a federal advisory committee appointed to provide advice and guidance to the Department of Health and Human Services and the Center for Disease Control regarding the practice of infection control and strategies for surveillance, prevention, and control of healthcare-associated infections, antimicrobial resistance, and related events in the United States healthcare settings. Dr. Kirksey and Dr. Gordon and Dr. Melissa, thank you so much for joining us. Please start by telling us how COVID-19 is so deadly and how it differs from other respiratory pandemics.
Thanks so much, Eric. I appreciate the introduction to me and my colleagues from the clinic. We also have another person that I'll briefly reintroduce the group to before we get into our primary presentation for the evening. This is Mr. Berlin Hamilton. Many of you within the President's Council know of him. He's the supply chain diversity lead director here at the Cleveland Clinic. Berlin, would you like to say a couple of words and then we can get on with our medical meeting?
Sure. Thank you for the invite. But I work very closely with Dr. Kirksey as well as the other clinicians here at the clinic. We believe that health disparities not only exist with health, but in the community as well as it relates to economic inclusion and development. So we just don't focus on the actual health of the patient, but also on the economic health of our patients as well. And my goal is to work with each and every one of you to make sure that we include you in all of the wonderful opportunities we have across the clinic. Many of you we've already worked with, and look forward to working with you and looking for opportunities to engage you further.
Berlin, I appreciate those comments. You know, when we spoke last, we talked about the One Anchor program and some of the different programs that were taking place here at the clinic, understanding that it's really, at the end of the day, social determinants at the heart of many of the health disorders that disproportionately affect our African American population, our community. Maybe you can make a couple of comments on that program.
Yeah, exactly. So again, we definitely know that disparities really stem from the economic health of our communities in which we serve. And our goal is to engage our community in the work that we do across our system. Typically, we spend anywhere around $3 billion or greater annually on products and services. And my office works very closely with the entire enterprise, as well as our clinicians, to find where the opportunities exist in our supply chain to engage diverse suppliers. We understand that there may be some development and growth that needs to occur in making that happen. And my office works very closely to make sure that we align with the needs of our organization. And we have lots of different development programs as well as direct programs that exist today to support our community, to engage our community.
Yeah, I think the most recent example announced in terms of the local development with the Myers Anchor grocery store represents a evidence that the Cleveland Clinic is invested in the community, understands that residential housing, safe communities, healthy and reasonably priced food. Many of these things drive our health issues, our health care. And I think that's a great example of what's happening in 2021.
Exactly. And we also have the our laundry facility that we've actually done a lot of work too around the community and getting some of our citizens back to work. So we actually invested over $50 million to build a laundry facility, and we're hiring people within the community to get them back employed.
Wonderful. Excellent. Well, thank you so much for your comments and your time. And hopefully at some point we'll be able to reconvene and maybe dedicate some time to one of these meetings to have some dialogue with the entire President's Council.
Sounds good. Look forward to it. Thank you.
Thanks again.
All right. Take care.
So our goal this evening to all of you on the call was really to look at this issue of COVID vaccination. We previously convened the group and briefed you all on COVID and its manifestations early on in the process. We continue to see that COVID-19 disproportionately affects African American and minority communities, with increased rates of hospitalization up to 4 times greater within the African American community and increased rates of death 3 times greater than in our white counterparts. This is a problem that continues. We also understand that the pathway forward is through the vaccination. Masking, social distancing, hand washing, all those things are very important, but this unique technology and medical innovation has provided us somewhat of a glimmer of hope and light at the end of this long tunnel of COVID. Having said that, within the African American community, there are historic events that have created mistrust. We all know of the Tuskegee experiment. There are many more. We're all familiar with those, and those have created sentiment that is somewhat reluctant and fearful of new medical technology innovation. This creates somewhat of a complex and an issue of cognitive dissonance in terms of, do we want to be first in line. That's something that I've been campaigning for over the last 6 months is when we have a vaccination, as African Americans, we want to ensure that our community is first in line and is not neglected in terms of the upfront distribution. That's in total conflict with how many of us feel. I, at some points in this process, have felt somewhat concerned about the process of investigation, research, and implementation of a vaccine program. What I will say is we understand, hopefully, in spite of what's happening, that as Erica alluded to in our country's capital today, we understand that we are hopefully moving forward beyond this process of politicization of the COVID-19 pandemic and moving to a more thoughtful era in this illness that we've experienced. And I will say that science should lead the way, and that is really why we're here this evening. I brought and convened Dr. Gordon, our infectious disease chairperson, and an expert on the vaccination and the science around the vaccination, Dr. Melissa Lee Yang, who will talk to you about distribution of the vaccine at the state's level and at the municipal, county, and local level, Cleveland Clinic's participation in that. Transparency is another issue that's very important. We also know that as a greater number of people are vaccinated, there will be patients that experience minor and maybe more moderate side effects, but there must be transparency, because as soon as there is a hint of the lack of transparency in this process, that will engender further sentiment of vaccine resistance within our community. And finally, as community leaders and business leaders, we ask that you understand and advocate at the local, community, and state level that we need funding to market, advertise, and promote to the African American community, our community, the safety around the vaccine, the excellent outcomes related to the vaccine, and the low rate of side effects secondary to the vaccination. I'm scheduled for my vaccine tomorrow. I know Dr. Gordon, I saw him on our website receiving his vaccine last week. Notables such as former President Obama have received their vaccination. I encourage all of you to do so. So with that, let's jump into the content of the evening with Dr. Gordon to present some information on the vaccine. And as Erica mentioned earlier, we'd like for this to be a dialogue and an interactive process. And so hopefully you'll raise your hand, you'll submit questions throughout the evening, and we'll get some questions answered and become educated and informed on the COVID vaccine.
Well, Lee, thank you very much. I want to start by it's just a pleasure to return to the President's Council. I admire you all so much. And as Dr. Kirksey said, I'm really here to learn from you, and we're really hoping to activate and engage the council to do what you do best in terms of empowerment, education, and taking care of our own kind of populations. You know, it's interesting watching some of the things today. I did a lot of training in Atlanta. And in Atlanta, it used to be, you know, the city's too busy to hate. And it's nice to see Georgia, I think, turning, and I think will lead the country hopefully to more tranquil times. And the pandemic, I think, in 2020, it's kind of been, unfortunately, a metaphor for a lot of troubles, but there's a lot of opportunities. Next slide, please. I'm having Erica going to be driving here. So I'm going to step out a little bit of my comfort zone and enter into yours a little bit, but I just want to give the highlights in terms of, now that I'm 9 months into this, a little bit about frameworks of interventions to stop the pandemic. And then obviously a little bit about vaccination in terms of the gateway to what we call herd immunity, although my colleague, Dr. Liang, is going to really get into the details. And then I really want to talk more about the disruptability index and how it's affected actually our economy, and in healthcare in particular, and education. And then in the end, I'll do a little bit of something you shouldn't do, and that's predicting the future, but forecasting in terms of when this pandemic is going to end. Next slide, please. So let's frame this up right now. Current state, as you know, in terms of the homeland, we're up to 20 million infections, 350,000 deaths. That is an astounding number that's hard to get your hands around. There are still many people that say, oh, this isn't bad. This is about the, this is about the just bad flu. But I want to show two graphs here. And if you look at the one on the left, where the arrow is, this looks at measuring kind of what we'd say the impact of the pandemic as we sit now in 2020 compared to the 1918 global pandemic of flu, and then compared to other respiratory pandemics we've seen. And as you look at severity measured by mortality, as well as transmissibility measured by number of cases, you can see that this pandemic that we are enduring now really steps up close to the 1918 pandemic that we read about. The other curve I want to show you is kind of where this is affecting, and this has informed us in terms of where we put our efforts. So the COVID-19 pandemic is really what we say an L-shaped curve. And what that means is, in the blue, you can see it outlined, is that in terms of at least severe disease and deaths, fortunately, it is not affecting our younger people. It's not to say that kids are immune, but we rarely are seeing what we would say deaths and mortality. It's mostly as it rises with age. And as people know, very few of us don't know people who are elderly or have died, that in our long-term care facilities, although they're only about 5% of the total cases, in the homeland, it's about 40% of the deaths. This contrasts with the pandemic flu of 1918, which was more of a W-shaped curve, meaning that, again, young people were affected as well as the older people. Next slide, please. That another way to kind of hopefully explain some of this in terms of why kids don't get as sick, and I know we're not all immunologists, but basically one of the thoughts is, based on studies, is that kids have a little bit more robust to what we would say an innate immune response, which is kind of a non-specific response, and potentially because they were exposed to more of non-COVID type, non-COVID-19 type of coronaviruses, whereas adults don't have that robust response. And so whatever the reason, it turns out, as I said, we're just all thankful that our children are not dying in great numbers, because that would look like a much different face in terms of our homes in the country. Next slide. Now, the other way I want to look at COVID-19 in terms of impact is other epidemics, pandemics, which I have actually grown up with as a physician. So COVID-19 in terms of mortality rate, that's 3 per 1,000, you can see at the top in black. Compare that to the Spanish flu again, which was about twice the mortality. And again, some of this has to do with medical technology. There were no ventilators in 1918 or other types of treatments. But then look at HIV. That's another pandemic that we know has affected populations disproportionately. But you can see that the impact pre-treatment was also about 3 deaths per 1,000. And then, of course, another concurrent epidemic that we're still dealing with, the opioid use disorder epidemic with overdoses. You can see, again, the death rate for that is about similar to COVID-19. Now, when we turn this around a little bit, and as epidemiologists, we like to look at not just deaths, but what we call years of productive life lost. And that adjusts for age. So obviously a 3-year-old that dies would lose about 70 years, as opposed to a 90-year-old that dies where there wouldn't be a lot of years productive loss. I'm not saying that there's not a tragedy in both. But then you can see really the impact of the epidemiology, because you can see COVID-19 again, relatively still significant, but relatively low compared to the Spanish flu, because again, a lot of young people died. And HIV, you can see is still very high, because disproportionately affects a lot of younger people, as the opioid use disorder. So these are different ways in terms of looking at different interventions in terms of the costs to society, without just looking at numbers and total deaths. Next slide, please. And so what we like to do, and I know a lot of you are into what we would say hazards models. This is from Reason, who is an economist and also a safety person. And basically, what we try to do to prevent an error or an adverse outcome is put up all these barriers in our process, safety checks. These are, quote unquote, the layers of Swiss cheese, so that it would really take an unusual event for all the holes to line up for something bad to happen. And if we apply this model to COVID-19, I can divide this up into what we call personal responsibilities. So that's like Melissa, myself, and Lee. You know, are we wearing our mask? Are we washing our hands? Are we doing our physical distancing? Then you can put the shared responsibilities. These are things that the government might rain down, like bar closures, or stay-at-home orders, or even mandatory masking. And that gets us somewhere. But you can see that last piece of the Swiss cheese, vaccine, we really believe that this will have the most important impact in terms of turning this pandemic around. Next slide.
Dr. Gordon, before we continue on, I want to make certain that we're able to address some of the questions that we have, because we have many.
Sure.
One is, why are Blacks disproportionately affected in the access to healthcare as well as pre-existing conditions?
So that's a very, it's a very complicated question, but as was mentioned before, there's something called the social determinants of health. So we know this is a strong thing. We can just look at someone's zip code, and that is a strong predictor of certain things in terms of both positive and negative, based upon, again, access to safety, schools, food deserts, and things of this nature. So some of that has to do with not biologic factors, but social economic factors. And when we talk about something like a respiratory pandemic, it's easy for someone like me in my household to kind of distance. Okay, I can work at home in terms of this nature. I don't have a multi-generational family in terms of here. That's not true for a lot of people. And so when we break this down, especially in an infectious disease such as COVID-19, which spreads in households, this really is, can people have the opportunities to stay safe? Look at all the people who are delivering our groceries or doing the manual labor or cleaning up even at the clinic in terms of this nature. This is also disproportionately young and people of color. And again, if they acquire it at work, they can bring it home, spread more. And then if there's underlying other concomitant diseases, such as obesity, diabetes, or things of this nature, then not only is you're going to get increase in infection rate, but increase in bad outcomes. People have also looked for, are there any quote unquote genetic factors that predispose? There have been some people look at blood group types and things of this nature, but by and large, the best explanations that we have for bad outcomes in terms of people infected with COVID is underlying disease as well as age. Next slide, please.
And Steve, I'll just make one comment to the questioner is, it's the same reason that we suffer disproportionately from cardiovascular disease, cancer. Not only do we suffer disproportionately, but we have worse outcomes compared to our non-Black counterparts. It's multiple levels, it's very complex, and it all begins within our communities and ends in the healthcare system at each level.
So to move on to, as we talked about vaccination, which we'll talk about, I like this book. It talks, she's not a physician, but on the cover you see, this goes back to kind of Greek mythology, but here's Thetis, the mother, dipping her infant son Achilles into the river Styx. There was a god that she had pissed off a little bit, and she was worried that her son was going to get attacked. So she dipped Achilles all the way into the river. Of course, the only part that she couldn't dip was the Achilles heel. And of course, that did come back to bite him several years later. But I think the important thing I want to say is vaccinations occur all the time passively between mother and child. Antibodies are delivered to the newborn from the mother, which protects that fetus for 6 months for certain things. And so immunization passively is a part of life and protection in nature. And I'd like this statement in terms of from the WHO, that this is really our goal. It's not a national goal, it's an international goal. This is to provide widespread availability and high community coverage with safe and effective COVID-19 vaccines for everybody. This is our aspirational goal. And again, we'll talk about the vaccine hesitancy, but we're not here yet. This is where we want to be. Next slide. I'm not going to get into the details of the types of vaccines, just to know that there are several that are way along. Most of us know the 2 mRNA vaccines that have emergency use authorization in the States. One of the adenovirus vector vaccines was just approved yesterday in the UK, in addition to, and there'll be several others, I think, coming online. So we'll have many different platforms coming out. There's some reasons why the mRNA actually jumped into the lead. But there was a comment I saw about it's hard to trust Operation Warp Speed or quickness. I want to emphasize that the vaccines went as fast as the speed of science. Nothing was rushed in terms of safety or regulation. It was that there was a lot of people globally working on this problem and a lot of money dedicated to it. But there were no regulatory shortcuts in terms of the US approved vaccinations in terms of trying to get a political victory. Next slide, please. I'm not going to go through the genetic platform, except to say that the mRNA from these vaccines does not get incorporated into your body. And so the mRNA, which is kind of is introduced and it kind of is how the vaccine ingenuity makes the antigen to the S protein. It makes your body produce that so that you can get a good immune response without actually getting the actual virus. But the mRNA is destroyed. It is inside the body cells. It never is incorporated into your body. Next slide.
Dr. Gordon, I have another few questions for you, particularly regarding the vaccines. One is, why is it referred to as the vaccine if there are very different COVID-19 vaccines? What are the variations and formulas developed by the 4 pharmaceutical distributors?
So I'm only focusing on the vaccines that have been approved in the United States at this point. And those are just the 2 mRNA vaccines, because I think if you look at, there's over 200 vaccines in the pipeline, so to speak, and there's many different platforms. But I'm only going to be focusing on the ones that are approved, because those are the ones most likely that we are going to be offered, or that you're going to be offered in the near future. I do predict that we're going to need different types of vaccines for different types of populations, however. And there's still, for instance, as we said, the adenovirus vector that you might have heard about in the UK, which uses a different type of technology. The Chinese, as you know, have a different platform. It's the heat-killed. The Russians also have an adenovirus vector called Sputnik. But I don't want to get into, how could I say, I wouldn't get into the details of those in particular, because a lot of that have not been published in peer review for me to comment on the safety. So the two products I'm focusing on, which are shown here, the efficacy, that the efficacy, meaning in these trials, which looked across race, gender, and age for the 2 mRNA vaccines that are currently approved, they are the efficacy, meaning the ability to protect against infection with COVID-19, was, you can see, about 95%, which is as high as any other vaccine that we talk about, measles, mumps, rubella, comparing that to about 60% for flu. So I do believe that these are not going to be the only vaccines, but I think we're fortunate that the mRNA vaccines appear to be the safest and at this point the most efficacious products, and they are now the ones that are going to be available first.
Another question.
Oh yeah, sure.
I'm sorry, Dr. Gordon.
No,
question
please.
is, participants want to know, will there be an option as to which vaccine they're able to choose, and how do they know which one to select?
It's a great question. So, I think, as Melissa will point out, right now at the clinic, there is no choice. I mean, both of these vaccines, as you can, efficacy are interchangeable in regards to their efficacy and side effect profile. They're both kind of constructed from the same background, and both had to submit their own individual safety reports to the FDA, which were extensive. And so for us, the best vaccine is the one that's available for us. So for instance, at the time that I got my vaccine, it was only Pfizer. Now we have both Pfizer and Moderna. So right now, we are not getting a choice, so to speak, and nor do I believe that we need a choice, because I do believe both are effective. There's a little bit more of a challenge with the Pfizer product that you might have heard about, because it requires that ultra cold chain. So that's why Moderna might be a little bit more available in certain areas of the country that don't necessarily have the deep freezers, because although it still has to remain frozen, it doesn't need to be frozen at minus 90 degrees Fahrenheit.
You mentioned the Pfizer vaccine, and the Pfizer requires 2 doses. If you don't receive both doses, then what happens?
It's a good question. So both these products out, in fact, even the AstraZeneca, all require 2 doses. And the 2 doses were designed for maximum efficacy. So the data is shown here, the 95% efficacy for prevention is based on receiving both doses either 3 to 4 weeks apart. As we all know, any vaccine that requires a return visit is complicated. Requires a patient to come back. We all would like that one and done, but we don't have that yet. And there have been estimates that if you get one dose, you may be protected 55%, but I want to emphasize studies were not done using a one dose arm. So that is still what I would call post hoc analysis. And we do encourage that it's a commitment for both doses. So when you make your appointment to get your vaccine, you're going to get 2 appointments, for the first one and 4 weeks later for your second one.
Steve, while we're on this topic, my understanding is that after the first dose with both of the vaccines, particularly the Pfizer vaccine, that about 10 days you have about 50% immunity is what I'm told.
Yeah, I think, Lee, for most vaccines, we don't think you're going to develop any type of effective antibody for about 10 to 14 days.
Yeah.
But I will tell you, I've already seen 2 patients who got COVID-19 within a week after getting the vaccine, not from COVID-19. I mean, not
Sure.
from the vaccine. And so I would still say that we would always encourage the intent to treat aspect would be that you're going to complete the 2 vaccines.
Absolutely. But I mean, that's just to say the 50% means that you don't have the full
Correct.
possible 95% immunity of the 2 prescribed vaccines with one. So you can't are not advised to take the shortcut.
Correct. Next slide, please. And so these are some of the frequently asked questions I think that many of you may have. The efficacy, as was stated, very, very high. We talk about the reactogenicity. That's the reaction to getting the vaccine intramuscularly. It is no more or less than other vaccines that we administer, from flu to Shingrix and everything else. To date, there's been no concerning safety signal in terms of this. And again, you can give with allergies, but as was mentioned in today's MMWR, if you have a history of what we would say anaphylaxis to any other vaccine or medication, that you will be watched closely in terms of this. And in all our vaccine centers, they do have the ability, if someone does have an anaphylactic reaction, to resuscitate. We have not seen that in 13,000, and there's been 21 cases of what we'd say potential anaphylaxis to date amongst 2 million people, no deaths. 17 of these people had known anaphylaxis in the past and had EpiPens already. In terms of durability, we don't know how long the protection lasts. And we also don't know necessarily how safe it is or not in pregnancy, although the ACIP, the governing body, has given a permissive to give to pregnant women because of the risk of COVID in pregnancy after consultation with the woman and her obstetrician. And because children weren't affected, the initial vaccine trials really didn't go after children. So kids greater than 16, we have no data, and it is not a pediatric vaccine at this time. Next slide, please. I do want to get in, and I'm sure that Melissa will talk about this, and this was the big discussions. So we talk about the science, we talk about implementation, but as was mentioned, there's a lot of ethics in terms of transparency, beneficence, making sure there's equality in terms of for populations that might be hard to reach, so that it's just not the white doctor getting in front of the line. Next slide. And this is the phased rollout. We're currently in phase 1A, which means we're still doing healthcare workers on the front line, although I think Dr. Lang will update us, is that we should have hopefully all of our frontline healthcare workers taken care of, hopefully within the next week or 2, as well as the long-term care facility residents and people there. Next, as you know, will be the elderly in the community and people immunosuppressed. But the hope is that we have enough vaccine product that we're just able to push out vaccine to anybody who wants it. Because as I stated, everyone has an indication above the age of 16. Next slide. Now, this gets to what was talked about before, and this is where we're going to need your help. So at the clinic, we have hospital workers kind of fighting each other, not literally, about, hey, wait a minute, I saw Lee get in line and I see more patients than him. So you have an educated workforce that is actually clamoring, emailing Melissa to get in front of the line, so to speak. But then if you do a survey that was published, and you see here, there are gaps. There are gaps in that men less kind of vaccine susceptible in terms of attitude than women. You can see, as Dr. Kirksey mentioned, race, ethnicity, people of color, you can see much lower, I would say, than Caucasians, except for Asians in terms of this. But look at African Americans are at the bottom there in terms of vaccine hesitancy. And then, of course, also education, inversely correlated. In age, a lot of younger people, less kind of believers in terms of vaccination. These are the things we're going to need help with in terms of peer-to-peer education at the ground level in terms of this. As Dr. Kirksey said, no, you need to get a piece of this. This is going to help you and your family and your community. This is not going to hinder it, and you don't want to lose the opportunity because there's a lot of virus out there. Next slide, please. I'm not going to spend too much time on mutations, but viruses mutate. Many of you may have heard about the quote unquote the UK strain in the United Kingdom, which doesn't appear to be any more virulent, but does appear to have increased transmission. This is bad news because this just means a virus that's already easy to catch, maybe even easier to catch. That means more people get infected, and even if it isn't as quote unquote just as virulent as the mutant strains, it just means more people will get infected and more people will, as a percentage, end up in the hospital. So this is something that obviously is another call for vaccination urgency. Next slide.
Steve, as much as I understand at this point, we believe that this variant is just as sensitive and responsive to the vaccine as the initial variant. Is that correct?
That's correct. We don't have any data yet that's being tested, but Lee, you're correct. And we even have researchers at the clinic looking at that. But again, what we don't know is why UK only. But as you can see with global travel, the amount of this virus in the UK and the amount of travel from UK to the States, that cartoon says the horse is out of the barn. I mean, this virus is just not in the UK. And as you're seeing more and more reports, as people are looking for it, there are pockets in not just in the United States, but across Europe as well. There's another variant strain that was described in South Africa in December with similar properties, but independently arose. And again, this is the urgency again for vaccination, as Dr. Kirksey said, another reason not to delay.
Steve, can you just touch on one more issue that I've heard out there? People hearing of this idea of herd immunity and not necessarily understanding this idea that it's of question and still uncertain what percentage of folks within the community would have to have had the virus or have had the vaccine. Anywhere above 60% is what I've heard. And so if you look at our national population, we're thinking that about at least 200 million people probably need to be vaccinated, notwithstanding young people less than 16 and those patients that have already had the COVID infection. That's a huge, huge number of people. And so those people hoping to sit on the sidelines saying, I'll just be safe, I won't take it, and we'll get herd immunity quickly and I won't need to take the virus. I think that's flawed thinking.
I would agree. This is unprecedented in terms of the number of people that we're trying to vaccinate, not just in the homeland, but globally. And I think Dr. Lang will talk about opportunities and challenges there because it's just not about vaccine production. That's a science and that gets us here. It's that what we call that last mile. That's what the Amazon talks about in all these fulfillment centers. It's that last mile. And I call that last mile from the freezer on frozen into arms. And next slide, I think I might have something on that. This is also something that I want to pivot to because I know there's a lot of business and smart people on, but COVID has been a disruptor. not just for us personally in terms of how it affects our family or the clinicians. But this is an interesting book by Scott Galloway, very good read, I thought. But if you look at the big four, he talks about that. Google, Amazon, Microsoft, and Apple, they prepared. I mean, it's not that they made this pandemic, but with their business structure in terms of vertically integrated and clouds, they were made for people that to deliver services to the home without getting out of your house, right? I threw Netflix in there too, because all of us, you got to do something else too in terms of streaming. So preparedness was rewarded here. In that slide on the bottom is not cases of COVID. Those are employees hired each month by Amazon. And as you know, we've got an Amazon fulfillment center on the east side where the old Magic Johnson Theater was in terms of this nature. So these aren't necessarily great jobs, but they're jobs. But it's a new economy. And I don't think we're going to move back. We had the gentleman on for supply chain, and he would have told us before COVID, the mantra is just in time, right? Dr. Kirksey stuff should be just in time. Melissa stuff just in time. I want the toilet paper just in time. But now we're thinking about just in case. And we are going to need local suppliers, not just for medicine, but for our masks and other things. We can't put all our eggs in overseas supply chains that could be compromised by another pandemic or something else. And hopefully, this is also going to bring jobs closer to home, which is a good thing, I think, for America. Next slide.
Dr. Gordon, I wanted to take a step back to distribution of the vaccine.
Yes.
One of the recurring questions is, what steps are being taken to ensure that the quality of the vaccine will not be jeopardized once it's distributed locally, especially in the inner cities?
It's another great question. The cold chain or the monitoring, the track and tracing of the product is almost like they're moving gold. So it's just amazing, and I'm sure Dr. Lang will talk about that. But in terms of how much time and effort in terms of checking and controlling. So the controls are there to make sure nothing has been thawed. Now, nothing's perfect. I think many of us heard about that pharmacist in Wisconsin that went off the rails a little bit and intentionally sabotage. Well, you can't control things like that, but this has been really handled exceptionally well in the clinic and other healthcare resources, as well as Walgreens and CVS. It put a lot of time into making sure that product that you get has not undergone any compromise in terms of quality. And so that's a good question. The other thing I think about disruption is we look at, Amazon and Google are looking at other spaces and they're going to follow the money. And if you look at where the federal government spends money, it's education. You can see about $1 billion in public education and hospitals and healthcare. And as much as we think we provide value, there are others that might look at the inflation of healthcare, like education, and say, look, you're in a space where there's been a dramatic increase in price over the past decade, but from a patient or a student point of view, I have not felt an increase in that value that's consummate with that. And that's that unearned margin. And this makes us ripe for disruption. So when you talk about that last mile, Amazon could probably deliver, well, we'll go to the next slide. I'll give you an example of COVID. So one of the things that is in now is, they're talking about getting other tests for COVID other than ones that require a laboratory like the clinic to do. So point of care testing in the home. Next slide. And many of you have seen this. So this is a very interesting assay. It's a molecular assay that can be done at home. Now, if you think about this, Amazon could certainly get this to your house very quickly with a pulse ox if needed, as well as if medications are needed, drop those as well. And then I would become the Uber driver. They would need me to talk to somebody, but you can see the disruption that could happen in healthcare delivery. Because if patients can do this test at home, why can't they do other tests at home? And why does it have to be provided by the clinic? Why can't it be a low-cost producer in terms of this nature? And again, I become the Uber driver. You would call me with the result, and then I would say, okay, do this, and then you'd say, thank you, doc, and then you get your medications or other things from another low-cost provider. So this is going to happen. Next slide. And I'm sure you guys have thought about it. Now, finally, I'll end with forecasting the end of the pandemic. And I guess I would start by what's my definition of end? And then I'm going to imply the Kubler-Ross model, the 5 stages of grief, which we've gone through. So that's denial, anger, bargaining, depression, and acceptance. So I define the pandemic will be over when it's accepted, meaning that COVID-19, when you hear that, it would be just like you hearing someone had the flu. You know, it's part of life. It's not going to disrupt you or disrupt us. It's just going to be a part of that. Now, how are we going to get there? Well, one is what Dr. Kirksey talked about. We will get to that 60 or 70% in the population, either by vaccination, hopefully, as opposed to natural infection. And that would be the one way. The second is it is possible for this virus to mutate itself into something that is pathogenic. We have other coronaviruses that cause colds and don't cause pandemics. I wouldn't bet on that, but that's possible. The third possibility is that it will just disappear. Remember SARS-1 kind of was here and gone. Now, I wouldn't count on that either because all of these have animal reservoirs and we've never eliminated a human disease where there's animal reservoir. Smallpox we eliminated, but smallpox does not have an animal reservoir. And the fourth would be we would evolve to become resistant, but that's going to take a long time. That will be long before Lee and I are here. Melissa probably will still be here, but you know I'm too old for that. So that's I think where we're going next. And finally, because I just want to lessons learned, you know, talking about animal diseases. Most of the new and emerging infectious diseases in our lifetimes come from animals. They're called zoonosis. And maybe some of you heard about, you know, they still produce minks for people to make clothes. And most of that goes on in Denmark and in Northern Europe. But the minks can get COVID. And not only that, these minks gave COVID to the workers. So they are culling or killing 17 million minks because of that. But remember, this won't be the last, what we call spillover to occur. And the hope is we're going to learn some lessons here in terms of detection, surveillance, and platforms so that we never have to endure a 2020 like we did before. There's a nice book that just came out, Apollo's Arrow, which a very, very good author in terms of a reference. Next slide. And finally, because I'm a, you know, kind of a medical person, and I have to leave on an Osler quote. So William Osler, who was a famous physician in the late 19th century, early 20th century, says humanity has but 3 great enemies: fever, famine, and war. And of these, by far the greatest, by far the most terrible, is fever. And with that, I will be quiet and happy to answer any questions after Dr. Liang presents.
Actually, I wanted to just take a pause here, and if there's anyone that has a question that they'd like to ask live, if you could click your raise the hand button, and we will call on you to take 2 or 3 questions right now.
And I'll jump in while people are raising their hands. So Steve, historically, we've had low rates of African-American and minority enrollment in research trials. In many national and federally funded trials, less than 20, 30%, especially in diseases that disproportionately affect African-Americans. How did African-Americans do in enrollment in these pivotal trials that led to this emergency use authorization?
That's a great question. I don't have the great specifics, but there was 20 to 30% of the population in both Pfizer and Moderna that were African-American, people of color. And again, a lot of trials were also done in the Oxford product in Brazil. I do want to shout out, you know, some of my best mentors at CDC and eye training were African-American physicians. Helene Gale. I mean, and remember, some of the developers of these vaccines were African Americans. I mean, we all know that. We know that there's bright and brilliant people of all colors and things, but we know that there's, how could I say, there's a strong and proud tradition of African American physicians in Cleveland area in this regard, and I think this is where the messaging I think also needs to come from in that peer-to-peer to be effective.
We have a question from Sheila Howard. Go ahead, Sheila.
Oh, yes. Hi. First of all, thank you for this presentation and thank you for this opportunity to ask questions. I know just talking with family and friends, one of the questions that come up quite often is that this vaccine was produced in less than a year. And history teaches us that research studies, you have to go through the animal studies, then you have to go through the human studies. I mean, it takes years before medications are approved. And so there's distrust in the quickness of this vaccine and distrust with not knowing what the side effects could possibly be. I just wondered if you could comment on that. That might create some comfort.
Yeah, Sheila, that's a good question. So, it's interesting. Actually the brain trust behind the Pfizer vaccine wasn't Pfizer. It was a husband and wife team who are German but Turkish nationality. And he gave a TED talk in probably 2 years ago. He was already working on mRNA vaccines, not for COVID, but for, at that point, it was going to be SARS-1. And of course, that never went anywhere because SARS-1 went away. But he predicted, he said, we are going to be able to use this technology for future diseases we don't know about. So these vaccines did not come out of nowhere. There was years and years of basic research that was being done on the platforms, either related to COVID, cousins of COVID or other pathogens. So all of this is iterative and built on, built on the research of others. Why it happened so quickly was because obviously we have new technologies regarding the sequencing that have been developed, but you also had a lot of people working worldwide on this problem, and a lot of money was given up front. So the US government made sure that these companies were going to be made whole, whether or not their vaccine ever got into arms. So they spent billions, even though they didn't know what they were necessarily buying, so that they had horses in the race with the hope that one or two would come to the finish line, and that did happen.
Okay, and the mRNA, is that stem cell, or is that using aborted something? I've been hearing about that.
I think what you might have been hearing is that some of the cultures of the coronavirus might be grown on embryonic cells in terms of this nature. But the mRNA that is injected is not from embryonic cells in terms of this nature. And our bodies make billions and billions of mRNA each day in our own cells. I mean, that is how our body uses that same machinery to produce proteins and things for human. What the vaccine technology does is trick our body into thinking that that's the human mRNA, and it just takes over to produce that spike protein, which is then expressed, and then our body reacts to that protein to make antibodies. So it's a lot safer because you're not getting a live vaccine. And that's also why it's permissive for people who are pregnant. It's not an absolute contraindication in terms of like other vaccines would be.
Okay, thank you. I appreciate that.
That's fantastic. Is Dr. Liang still on? I don't know if...
Yep, I'm here.
Great. So maybe we can continue to see some raised hands. I appreciate that was a fantastic presentation by Dr. Gordon. I certainly am better informed on some of the science around the vaccine. Dr. Liang is here to discuss some of the issues around distribution. Dr. Liang?
Before we go on to Dr. Liang, we have one more question from Dawn Jackson, and then we'll go right into Dr. Liang.
The previous speaker had mentioned that they have been working on mRNA technology for 20 years, but is there any type of long-term research as far as side effects? And also for those who have like complicated medical histories, autoimmune disorders, I know they tried to, for trials, I know they tried to do like people who are more susceptible, like the elderly and things like that, but is there any type of information for those who have complex medical histories?
Yeah, thanks, Ms. Jackson. So the trials did enroll people who had underlying kind of medical conditions, including some people HIV. The numbers weren't high enough, however, to actually make extremely strong statements. But because it's not a live vaccine, because of the safety profile, there was no contraindications in terms of immunizing people, let's say, that were potentially transplant patients, had autoimmune diseases, or were even HIV. And there were some even pregnant people that received vaccine. I mean, even though they did pregnancy tests, that's not, it wasn't by intention, and no adverse outcomes reported, although those numbers are small. Having said that, now there's trials ongoing looking at those specific populations, looking at pregnant women, looking at very immunocompromised patients, including HIV and transplants. So those studies will roll out, as well as looking at kids.
And I would echo Dr. Kirksey. I would echo Dr. Gordon's sentiment, in that I've heard from friends and family members that, I have diabetes and I'm afraid to get this immunization because I have diabetes. Those are exactly the people that need to be at the front of the line. Those people that are multiple comorbidities, obesity, hypertension, heart failure, diabetes, those issues. Those are the people that need to be at the front of the line, as much as we know, because those are the people that have the highest risk from the COVID-19 infection if they actually have natural infection.
And then I just have one more question too. Part of, for the poll, I responded that I was COVID hesitant to the vaccine. And part of the reason is I have a chronic illness. I deal with the medical field a lot in work and as a patient. And one of my concerns is that it's always hindsight. That's 2020. The speaker mentioned like opioids and stuff like that. That was supposed to be a miracle drug when it came out. And then, 10, 20 years down the line, we see the type of effects that it has. So one thing that makes me want to wait a little bit is just so we can have the benefit of hindsight, a little more insight.
So thank you for that. If I can respond, I appreciate the vaccine hesitancy. I think we need the dialogue. I mean, we need to meet people where they are in patients, and we do that all the time. I just hopefully go into conversations, even if I feel strongly about something, that I will give you the opportunity to change my mind. And it sounds like you're, that. So I respect your opinion here. I will keep on talking to you in dialogue, in terms of trying to give you more data to get to that point where hopefully your hesitancy will turn into acceptance. But I respect your decision.
Dr. Melissa?
Yep, thanks. It says that I cannot share my screen. Can you enable me to share my screen? So while we're waiting for that, again, I really appreciate the questions. These are very good questions. And I think over the past month, my goal is to make that last mile work, to what Dr. Gordon was saying, to get as many shots into arms as possible, because that really is going to be the way that we're going to be able to end this pandemic. Herd immunity. If we were to contract the disease, millions more will die before we get to herd immunity. Again, my goal is to get as many people vaccinated as quickly as possible. In the state of Ohio, I believe we have 75 deaths per day in Ohio. And Steve, you can correct me if I'm wrong. It could be 75 or 125 deaths per day. And so a month's delay results in thousands of people dying when there is a vaccine available. So I do want to emphasize the urgency of getting vaccinated. And what keeps me going is that this vaccination effort is going to save lives. So I hope you can see my screen.
Yes, we can.
Okay, and it should be showing the phase 1A Ohio vaccination program.
Yes.
And so we are in the middle of phase 1A, where we are vaccinating healthcare workers, as well as residents and staff at nursing homes, assisted living facilities, at state psychiatric hospitals, as well as those in group homes, in veteran homes, and EMS responders. And those vaccines are being offered to those who choose to receive it. And we will soon be pivoting to phase 1B, where we will start vaccinating the public. And that will be ages 65 and above. So again, adults ages 65 and above. Also those with severe congenital, developmental, or early onset medical disorders. And a major goal is to vaccinate K-12 teachers and staff. And that is going to be a total of 2.2 million people. For phase 1A, it's about 1 million people. And just to let you know about the acceptance rates across the state right now, amongst the nursing home staff, those who are being vaccinated is about 40%. There is a higher acceptance rate amongst the residents, and that is 75 to 80%. Amongst healthcare workers, the acceptance rate has been 50% across the state. Dr. Gordon shared something similar to this. This is for the whole country in terms of the CDC phase COVID-19 vaccine rollout. So I did want to just share what happens after phase 1A and then what will happen after phase 1B. We would then go into phase 1C, where persons between the ages of 16 to 64 with high-risk medical conditions will be offered the vaccine, as well as other essential workers. And then over time, over the next several months, in phase 2, all others above the age of 16 years of age can be vaccinated. And so this will probably get us into the summer of 2021. So I just wanted to provide some information regarding the timeline of the vaccine rollout, when you should be expecting the public to be able to receive vaccine, and who those priority groups are. Somebody had asked about distribution of the vaccine. I will tell you that vaccine doses, particularly with the Pfizer vaccine, which is in the ultra cold freezers, those are all shipped with police or security officers to follow every box of those Pfizer vaccines that go out. With Moderna, those doses are distributed by McKesson Distribution Center, and those are also highly protected vials to ensure that they get to the health facilities or the local health departments that are going to be distributing them. So there is a lot of security, as well as a lot of strict precautions to follow in terms of getting the vaccine where it needs to be, and then administering the doses as safely as possible. So I'll stop sharing now. Any questions?
We have a couple of questions that were in the Q&A thread, but again, if there's anyone that has a question they'd like to ask live, please click the raise your hand button. One of the questions is, how long does the vaccine work?
Again, as mentioned, the durability, meaning the duration of protection, is not clear at this time. We do know, the data that has been presented thus far looked at 2 months after vaccine, but those studies are being extended. And so we are going to continue to have more data on that. But that's a key question, because we don't know whether this will be an annual vaccine, a one and done, or I should say a 2 and done vaccine. So stay tuned on that. We just don't know.
Dr. Melissa, when you're talking about distribution, how soon will there be shots in arms available for the general public?
So the governor wants that to happen yesterday. But the goal is to roll out phase 1B over the next 2 to 3 weeks. So certainly by the end of January, in fact, some communities are starting patient-facing vaccines already across the state because they are finished with phase 1A. But the goal for the governor is to get phase 1B workers vaccinated by March 1st.
Erica Mills states that the K-12 population will be vaccinated. How would this protect the student population? The adults might be protected, but the student population will still be transmitting the virus to each other. Do any of you have any comment on that?
It's a great question. There's no question that kids do get infected and that kids can transmit, but you know, if you look at big school systems, and I'll look at New York City as one, is that they did not sustain a lot of what we would say large outbreaks in the schools when using the non-pharmacologic interventions. And so the other side of that is we know that kids are tied to parents or to, in that if the kids can't get to school, that you're tying down a household or things of this, that's an essential component for most households, is to keep those schools open. And in most of the cases, it's the teachers unions appropriately are saying, we want to be protected because a lot of the kids can get infected, but not a lot of symptoms. But that's not necessarily true for teachers, especially teachers if they have underlying risk factors. Like I said, we don't have a vaccine for the kids, in part because the deaths and the bad disease don't usually occur there. That may come in the second wave of production. So right now, I think teachers are appropriately, as well as the people that clean the schools and are interactive, are essential workers that are going to be geared to getting vaccine. And if I was a governor, yes, I'd be prioritizing keeping my schools open and making sure the people that are administering to those kids are vaccinated.
We have a question from Jackie Dalton.
Hey, Erica, Dr. Li Ying, when we talked about the phases for the vaccination, the adoption rates can vary. So if the adoption rates are lower, would those phases move more quickly?
That's a very good question, because then you would have more vaccine allotment to move into the next phase. And so I will tell you that some communities across the state have had lower acceptance rates for phase 1A and have been able to move into phase 1B. So the answer would be yes, because again, our ability to move into the next phase is based on vaccine supply, as well as based on a certain percentage of completing phase 1A and then phase 1B. So that's a great question. And your assumption is correct.
Thank you.
Sheila Howard has a question.
Yeah, I just wanted to ask, was there any institutional review board oversight for the COVID-19 clinical trials that were performed, or any kind of oversight at all?
Another great question. So there was international oversight boards, which included multiple, what we would say study review boards, interim analysis to make sure that there wasn't anything adverse signals going on throughout the whole trial. That was well represented by ethicists, by physicians, as well as even patient representation there. So another great question, but yes, there was multiple layers of oversight in all parts of all these vaccine trials.
Thank you.
Dawn Jackson.
I was just curious, with the phasing of the vaccinations, is there any idea of, well, I guess it's more appropriate to say, from the public opinion, it seems like people feel like, okay, we get vaccinated and then we don't need to stay at home, or we don't need to wear masks. Is that an accurate picture, or do you think there will still be some limitations as far as safety protocols?
You know, it's another great question. Right now, even though some of us will complete our vaccination, we will still be wearing masks and appropriate protection and practicing distance in the community. Two reasons for that is we still don't know whether or not if you get vaccinated, you still might be able to carry and transmit. There'll be some data coming out later this month that will probably suggest that it does protect against transmission. The second thing is we still would like to see community rates of positivity and transmission less than 5%. So I think what you're getting at is, when are we going to say it's over, or when can we kind of relax as a population? That question might differ based upon those who have completed vaccination. You also are going to see some businesses, potentially airlines, set up something that if you have proof of vaccination, you might get some sort of preferential treatment as opposed to not. But we're just going to have to wait and see what happens. Right now, as you know, Ms. Jackson, there's just too much virus out there. I mean, although we plateaued, we still have about 500 patients in the hospital with COVID-19, and our positivity rate for people with symptoms is still 36%. That's just too much.
We have a question from Leangela Aiken.
Thank you. And thank you for doing this. This is great information. I'm actually logged in from Florida. But my question is, what is the shelf life of both of the current vaccines? And what controls are in place after the vaccines have been delivered to the distribution points?
I'll give that one to Melissa.
So the shelf life, so for Pfizer in the ultra cold freezer, it wouldn't be actually shelf, but it would be in the freezer. They're good for 6 months. And then once out of the freezer, once you put them in the refrigerator, it's 5 days. And once you open up a vial, it is 8 hours. And Moderna, which doesn't need to be in the ultra cold freezer, similar, once it's in a refrigerator, it's actually 6 months as in keeping it in the refrigerator, but then once it's in room air and you puncture the vial, it is 6 hours that you have to use it. And in terms of some of the precautions that we have, these vials are being managed by pharmacists. And so this is why a large portion of the Pfizer vaccine has been distributed to CVS and Walgreens in terms of the federal rollout of nursing home vaccinations, because they have a large army of pharmacists who are able to track the doses and be able to safely manage the vaccine vials.
We have time for a couple of more questions.
I think there was a question regarding side effects that we've seen at the clinic from the vaccine. And I wrote down I was going to answer this live, so clicked on the button. So we have vaccinated, I think almost 14,000 of our caregivers so far. And we have seen 4 folks, it may be 5 now, who did have mild allergic reactions afterwards. So we do have we do monitor folks for 15 minutes after they receive the vaccine. We have had several people have fever and pain at the site of injection, as well as headache. But from our almost 14,000 caregivers, there have been no major side effects. And the question of would teachers have to be vaccinated again in 2 months, the answer that Dr. Gordon gave in terms of the durability of the vaccine, we just actually don't know right now. But the answer to that question would be no, they would not need to be vaccinated again in 2 months to maintain immunity. But I don't think that there is a clear answer in terms of how long the immunity lasts for.
One last question, doctors. Do you see a point where the vaccine will become mandatory?
It's an interesting question. When we talk about mandatory, and my colleague Dr. Lang would immediately tell me, okay, how are you going to enforce it? And I think you don't want to get in a situation, I think, where you are making something easy to say, you have to do something. Most people, I think, if they understand the why, it should follow, if in terms of the value. Now, you might come up with certain circumstances where employees are, you're working with such patients that may be at risk of, if they got COVID, or in a certain situation, if you're dealing with animals, that if they got COVID, you'd wipe out this whole genetic, mouse or ferret farm, where some employers might mandate that as a level of protection. As we do know, we do mandate flu, influenza, so it's not out of the question. I just think at this point, I don't see us doing the M word at this time. It's more, as Dr. Lang says, is just trying to get that vaccine into arms, meeting people where they are, educating and explaining the why. Melissa, you might have other viewpoints on that.
Yeah, I think that, I think Dr. Fauci actually also commented on this, right? That, until there is possibly longer term safety data on the vaccine, I don't think that we can make it mandatory.
Doctors, thank you all so much for sharing this vital information. There are certainly many more questions, but we appreciate the opportunity to ask the questions that we were able to pose this evening. As we conclude today's webinar, we encourage each of our participants to continue to ask questions, to answer the polls that will be distributed. And if there are additional questions that you would like to have submitted to the doctors, please feel free to forward those to the President's Council. We also encourage you to stay connected with the President's Council by following, liking, and subscribing to our social media channels. We want and need to hear from you about the things that are important to our Black businesses and our Black communities. A link to today's webinar, along with slide presentations, will be shared with each participant. And for more information about joining the President's Council Business Chamber, please visit our website or contact our office directly at 216-771-8702. Thank you all again for joining us this evening. Stay safe and stay blessed.
Thank you. Have a good evening. Thanks all.
Thank you, everyone.
Bye-bye.